So Dr. Samia, are you on?
Yes, I am, Sylvia. And
right.
I don't know if you have everybody who you would have liked to attend.
Yes, we have a good number. We are good. I believe we're live in studio on Science TV. So yeah, we're good to go. We are catering for a very broad, what do we say? Our guests are everywhere. So we currently have a very good number. So we're good to go. We can proceed, don't worry.
Okay, so today, I think that we really should have, as you say, what we call sort of like listening and sharing sessions.
Yeah. Mm-hmm.
I wouldn't want it to be sort of like a one-sided sort of talk. Mm-hmm. So I think that I will give a very brief presentation around the perinatal risks for epilepsy, meaning what are some of the things that go wrong in either during pregnancy, delivery, or soon after delivery that may lead to epilepsy. So don't focus on the data. It's just one of the background things that we can talk about. And I think that the rest of the session could be open to discussion, to things that either are said or things that may be related to your own experience. I think the rest of the session should just be about sharing things that we know and things that can be of benefit to the group of parents who are present today. So Sylvia, is that a good plan?
Yes, over to you. That's a good, perfect plan. Then we can be able to at least engage the parents, the ones who have, we have a few questions that came in, and I'm sure there are others who will be engaging and asking, so they'll be able to handle all of them. So yeah, we're good to go.
Okay, fine. I will share my screen. Oh, there's no screen sharing. It's okay then, no problem, absolutely not.
I can
Sylvia, it's fine.
No,
it's perfectly okay. It's perfectly fine. Okay, no, it actually makes it easier to move faster.
No, you shared
yeah, because I hadn't wanted it to be a long talk anyway.
Mm-hmm.
So basically, I think one of the things, as I said earlier, the section of epilepsy that I wanted to focus on today is about perinatal risk factors and the epilepsies. So in Kenya, we are lucky that we have had so many studies already conducted to try and find out how frequent epilepsy is, what are the causes. What is probably missing is more studies into outcomes for children with epilepsy, as well as studies into the treatments that we are offering right now and what it is that can be offered to make things better. So already we know that in Kenya we have the prevalence of epilepsy at approximately 41 in every 1,000 children, which means that if half of our population is under 18 approximately, and we have about 47 million Kenyans at the moment, it just means that we have a significant number of them that live with epilepsy. So that's 41 for every 1,000 children that is born in our country. And approximately 11 out of those 41, their epilepsy will not be well controlled. Data that had been provided to us from Kilifi a long time ago when it was a district, actually not so long ago, we look at 2010 approximately, it just showed that perinatal events, that is things that may go wrong either close to delivery, soon after delivery, or during delivery, they contribute to about 5% of the cases of epilepsy. So that means that mothers who undergo prolonged labor, mothers who have, say, bleeding in late pregnancy, during delivery, before the baby is delivered, and also I'd mentioned prolonged labor where the baby probably comes out without breathing, those children are at risk for epilepsy. So the other factor that we know in our country has contributed significantly to the occurrence of epilepsy is the presence of what we call neonatal sepsis or infections in the newborn. So immediately a baby is born, we know that a prolonged labor is not a good thing because the baby then remains in the birth canal or close to the birth canal for longer than is necessary. During that time, they could inhale secretions from the birth canal or contaminants from the birth monitoring process. As people or as healthcare workers monitor that process, contamination can also happen. And the neonate may then, or the newborn baby may then inhale those infected or contaminated secretions, end up with an infection. And because the brain is one of the most immature parts of a baby when they're born, then the brain is very vulnerable to infection. And infections around that time have also been positively linked to epilepsy in our country. So it's thought that the neonatal seizures, seizures that happen in the newborn period, about half of them were as a result of infections at that time. So depending upon where you live, the other factors that have been identified include malaria. Malaria in the mother during, say, the last trimester. It changes the way the body functions, and the mother may also get problems like seizures in herself. She may have anemia. While she's having malaria, she may also contract other infections, including bacterial infections. So malaria in pregnancy, especially so the last trimester, can lead to preterm birth, where a baby is born before they're quite ready. And we've also talked about other complications in the mother, which may lead to epilepsy in a child. For example, if she has a seizure herself during a malarial infection, that in itself interferes with blood supply to the brain of the unborn baby, and that baby then may develop epilepsy in the final analysis. So soon after delivery, even if everything goes well, once again, there are certain factors that can lead to epilepsy in a small child or even in later life. Once again, infections are important. They contribute to another maybe 20%. If a baby soon after delivery has infections or before age 1 has problems like meningitis or what we call meningoencephalitis, that is infection of the brain itself plus its coverings, or unfortunately gets conditions such as tuberculosis or even severe malaria, all these have also been known to lead to contribute to epilepsy. Of course, there are other factors that are not related to infection. For example, if a baby is born with a brain that is not formed properly, which is something we discover during the course of investigation or trying to find out why the baby has epilepsy. Brain malformations are not very common, but they contribute to about 5 to 10% of another 5 to 10% of the causes for epilepsy in our country. Then we also have inherited problems such as sickle cell disease, which is quite common, say in the coastal areas, Western province, or what used to be called Western province in Kenya, as well as Nyanza. We have certain groups in our country who carry the genes for sickle cell disease. And so if a young child inherits 2 of these genes from both parents, they may end up with a severe form of sickle cell disease. And as a result of that, then they may end up with epilepsy. Then finally, we have, and one of the reasons why people get epilepsy in relation to sickle cell disease is because sickle cell disease in itself can also cause strokes. They can cause stroke. It can cause stroke in a young, that is, a stroke is basically an interruption in the circulation of the brain, or the blood circulation in the brain for this young child. And then once the stroke has happened, then part of the brain may not survive. And if those cells die and you form scar tissue inside the brain, then that scar tissue is active and actually causes epilepsy. Then the other common problem we have in our country is trauma, basically traumatic head injuries. We've heard of stories where children are not well treated at home. For various reasons, they may undergo non-accidental injury. For instance, if a child is involved in a fight with an adult, or falls from a height, which is now accidental injury. And some of the commonest forms of accidental injuries involve like boda accidents. You've seen around children being carried around, they have no helmets, they're involved in these accidents. That in itself can also lead to epilepsy in the future, even if the child comes out of that episode without many other injuries. Road traffic accidents are also important. We have seen parents sitting in the front seat or driving with children with them at the wheel. This child is not belted. So when an accident happens, the child suffers even more than the adult because they're smaller. And so they tend to be thrown around quite a bit. We have received children who were collected very far away from the vehicle in which they were traveling, because if the windows are open, then the children just fly out if they're not belted. So once again, another 10% of the children who have epilepsy in our country, it may be related to road traffic accidents. Then finally, we have another large group of approximately 30% of children where, despite our best effort, we cannot always pinpoint a cause for the epilepsy in this child. And a lot of times that is because the child carries a genetic change, which then predisposes them to seizures. So this genetic change could be that it has happened for the first time in that family, in that child. In some instances, we find that there are other family members, like maybe cousins, that is maybe nieces and nephews to the parents who bring the child, brothers and sisters, that is uncles and aunties to this individual child, and sometimes even grandparents. So for genetics, it's possible that the MRI brain or any other form of imaging you do may be normal. It is possible that other investigations, such as an EEG, may show communication problems. So genetics basically plays a very important role in the, in the occurrence of epilepsy in children. And sometimes it's very baffling for families when they come to us and they ask, what is the problem? Why does my child have this issue? The tests were normal. So a lot of times you find that, yes, this genetic aspect is the main contributor to that presentation. So in the world currently, it is possible to evaluate for genetic problems. It's just that it's quite expensive in our country because these tests are not done very frequently. When you do access them, we're looking at about 150,000 Kenya shillings for a genetics panel. And the genetics panel would also vary because initially we only were able to evaluate like about 100 genes, which are frequently associated with epilepsy. And these days we have panels that evaluate up to 400 genes. So depending upon availability, the fact that even the genetic test comes out negative, it doesn't mean that that is not the reason. So finally, I also wanted to talk about other problems that a child may have that may contribute to epilepsy, but occur outside the brain. For example, we have observed children with congenital heart disease. You've heard about children who are born with a hole in the heart. A number of them will develop epilepsy, and we think that it is because when the brain is being formed, when you have an unusual formation in the heart, that too affects how the brain is oxygenated or changes blood supply to the brain. It could be episodic, it may not have the right oxygen concentration. There are many reasons why that can happen. So also body malformations outside the brain have also been associated with epilepsy. This is a small number, but it's an important thing to know, because sometimes families of children like those, they sit and wonder, why is it that this child has more than one problem? Then finally, we hadn't also talked about some other conditions in pregnancy that have been found, not just in our country, but also in other places, to contribute to a small percentage of children with epilepsy. I'm talking about mothers who have diabetes mellitus, or sukari, as some people would call it, especially so when it is poorly controlled. And even then, that is, they keep having very high sugars or very low sugars. Such children born of moms with such problems, they can end up with epilepsy. And then finally, also high blood pressure in pregnancy is also one of those factors. So I think I will stop there. And as I said, I did not want it to make it a long talk or a very technical talk. I just wanted to give you some ideas about the things we already know in our country contribute to epilepsy. Thank you.
Thank you very much, Dr. Samia. I also have learned. I thought I have read vastly, but at least I'm learning every day. And it's something that many of us as parents actually wonder what happened, what went wrong. But I'd like for us to touch a bit on the difference between a convulsive disorder and epilepsy, and also the different types, because there are moments you hear parents saying, my child is twitching, my child is behaving funny, zoning off. Could you just like guide and try and paint a picture for those who maybe might not be conversant with what we're talking about, like what happens in the body during that time, so that at least we can enlighten maybe there are those who do not know actually that the child is going through a seizure and yet it is happening.
Okay, the correct term to use is actually epilepsy. Once somebody has had at least 2 events more than 24 hours apart as a result of abnormal brain functioning, and they end up with some of the signs or symptoms that you point out, where a child is no longer himself. He may look confused. He may have eye fluttering. He may have staring. He may be, but the hallmark is mostly unresponsiveness or altered responsiveness. We have very many types of seizures. The most important thing is to be sure that there's nothing else causing this presentation. So that is why evaluation or investigation is important, because once we know that the only factor contributing to this presentation is abnormal brain function, then we are very comfortable to label it epilepsy. Somebody can lose responsiveness for many reasons. For example, if you're having an abnormal heart function or an abnormal heart rhythm, could get an episode of fainting, which we call these things. And sometimes people use convulsive disorder loosely, to mean a situation where somebody has lost consciousness or somebody has had an episode of altered consciousness. So convulsive disorder, and sometimes even seizure disorder, is basically just a loose term. But epilepsy is more specific, and it encompasses very many seizure types. Some children will fall in what most people would understand kifafa to be, where you fall, you shake both sides, you have saliva coming out of your mouth, and a few people may even have incontinence. But in children, it's not always like that, even for adults. But because we are children specialists, we will confine ourselves to children. Children may have nothing else but just staring and fluttering, and they continue with what it is that they were doing. Just an interruption in their regular activity. You see that the child is not with you, and then snaps out of it and goes on. So we have that kind of seizure type. The child may say, I feel funny, I hear things, there's something with my stomach, and maybe then they keep quiet. They may look like they're chewing something. You cannot make them respond at that time. It usually will last about a minute or less, and then the child continues. Once you see something like that, sometimes even as a parent, you wonder, what did I just see? Did it actually happen? So there are many seizure types, so to say. There's some who just get shaking and jerking on only one side, and yet they're fully alert. They can even tell you what they're feeling, what is happening. They're trying to hold that hand. They're looking very scared. They can still talk to you, but they are still having a seizure. So children will have different seizure types, but once you can definitively report that it happens the same way, we've had at least 2 times, it wasn't caused by anything, then most likely that is epilepsy, and that is the correct term.
So we for us who are trying to console ourselves saying, my child only has a convulsive disorder, we better embrace it, because epilepsy makes it very heavy. It makes it personally, it just makes it this other thing, especially for us whose kids have now the convulsion as a comorbid, like when you have autism, then you have convulsions, or you have cerebral palsy or Down syndrome, and then now you have also the seizures on top of that. So when we add this other heavy word on it just feels like, dear Lord, do that to be there. So we play it safe that way, and ensure that we have what do you call this? That as a safe word, for lack of a better word. And then the other thing about the effects of when now the children have prolonged seizures. At what point as a parent should I panic, apart from when you said like involuntarily, if it comes more than once or twice in a specific period of time? At what point should we panic? Because you have moments where we have the short episodes, we have the moments of where the child stares in a daze and is blank. Then on top of that, we find the time where you have a seizure for a long time, and after which the child either passes stool or pees. And most of the time you're told that is like a danger sign. Why would you, what is that all about? Like what happens to the body of the baby at that point that it resolves to this? Kindly just enlighten us on that.
Okay, first and foremost, as the caregiver of a child, you're advised not to ever panic. Panic is not a good word. It's not a good situation to be in. And the reason why I say that is because your child is actually dependent on your own stability for their safety, because they themselves in that situation, they cannot protect themselves. So I guess the correct way to, or rather what you're asking is, when do I need to take action? Yeah. So basically, once a seizure has started, there are only 2 other things that can happen. That one, it will terminate by itself without any medication. And if it's going to terminate it by itself, usually that happens within the first 3 to 5 minutes. So if you're having seizures that are happening 2 or 3 times in a day, you really do need to go to hospital. Why? Because once a child has had more than, one seizure in a day, that is, you had one, for example, at 8 a.m., you've had another one at about 9 o'clock, you're now looking at a third one at 10 o'clock, it is very likely that these seizures will continue unless something else is given. So the other situation is where a child continues with having seizures for longer than 5 minutes. 5 minutes is universally or globally accepted as the outer limit by which a healthcare worker really must intervene. Any seizure that goes beyond 5 minutes it's likely to go on for much longer. So seizures which are lasting less than 5 minutes, usually there isn't much injury to the brain that happens, but the longer a seizure goes on, the higher the likelihood that it will cause permanent changes to some of the nerves or some of the neurons, as we call them, in the brain, or that other changes that are detrimental to the child may happen. For example, as they're choking and coughing, sometimes the secretions will go the wrong way, you understand? And so in a seizure that goes on beyond 5 minutes, you need to be concerned and be making your way to a place near you where they can assist end the seizure. It usually doesn't have to be your regular hospital, because your regular hospital could be very far away. But we get concerned about seizures that last longer than 5 minutes. So regarding the initial interventions, when a child has had a convulsion or a seizure, so to speak, it's best to lay them on the left side, allow whatever is in the mouth come out. Do not put anything into the mouth. Don't try to feed them, don't put in a stick, don't put in a spoon to try and protect them from biting the tongue. The tongue is very mobile, it's rarely bitten, and even if there's a bite, it tends to heal by very quickly. You could actually cause more injury to this child by putting something in the mouth. So don't put anything in the mouth. Make sure there's nothing around them that can injure them. Make sure that their face is they're not facing down into a soft pillow. Put them on a firm surface. Let them lie on their left side. Loosen any tight clothing. And if you're in public, just ask people to give him or her space. Then after that, move the child as soon as you can to a safe place. And if the seizure is clearly ongoing beyond 5 minutes, you really should be making your way to hospital. And as I mentioned earlier, also children who have multiple seizures in a day, whether they're on treatment or not, I think those are children who ideally should also be attended to sooner than later. Also depending upon how well the mother or the parent understands the child. Very long answer, right?
It's long, worthwhile, precise, and exactly what we need to hear. Because even in school, when we're looking at the first aid that we're given, they always say when someone gets like an epileptic attack, put them on the side, put the spoon in the mouth. So I'm sure in school, that's what they're taught. So then that means we need to have our education department corrected in that. And yes, I can see we have someone's
Patricia has.
Patricia.
Yes.
Yes. Patricia has a question. Patricia, yes, please come on board and ask.
Okay, thank you so much, Sylvia and Daktari.
Yes.
I just wanted to inquire, I didn't hear Daktari touch on infantile spasms. I was requesting to just know the difference between IS and epilepsy, or is it epilepsy or is it a seizure? Where do we put it?
Okay, thank you, Patricia, for that question. Today, the brief discussion we had was just about causation. What is it that causes epilepsy? What do we know already about that? So today we did not discuss what we call epilepsy syndromes. And what you're asking about is an epilepsy syndrome. Infantile spasms is basically an epilepsy syndrome, meaning it is a group of characteristics that tend to occur in certain children consistently. So yes, it's a form of epilepsy, and these will be children who are usually 6 months and below. A lot of times you will find there was a problem either before birth or during birth. For the vast majority, when we do the imaging or the pictures of the brain, very frequently we will find a problem, meaning either the brain didn't form properly or there was injury for whatever reason. And then the seizures tend to be characteristic. They tend to have this forward sort of bending, bringing the hands up and the legs, and then they do that in clusters. The baby looks like they're in pain because they cry after that, and it can happen many times in a day. Then if the baby had already started smiling, cooing, looking at mom, holding the neck, or even sitting, you'll notice that most of them regress. Then when you do the EEG, a lot of times you will find a specific pattern, very disorganized, that causes worry even for the clinician. So that's what defines infantile spasms. It is a specific form of epilepsy.
Okay. Okay. I know being in the groups with a lot of the caregivers, I see a lot of that spastic and all that. So those are types of epilepsy, or are they just types of how it presents itself? Like, how do we clarify that? What's the difference of the spasms and now the full body convulsions? Because there is a parent who's saying, like, one side of the child is the one that just reacts. Like, the jerks are on one side. Others talk about the eyes twitching constantly. And also, like, for my child, I noticed sometimes when he's asleep, he just does like jerks, like he's I'm trying to find the right words to explain it. It's like he got startled, but he's asleep. So of course, for us as mothers, they're like, oh my God, what's going on? You know, especially when you have a history of convulsions and when there is things like febrile convulsions. Just take us through about these different types so that we are able to maybe support other parents that we know may not be aware, because we also found out that there are parents and caregivers who are not aware that actually that is epilepsy presenting itself. How do we identify the difference?
Okay.
Mm-hmm.
Okay, I think really, I think I'll go with the first question you asked about the difference between infantile spasms and spasms. So as I said earlier, infantile spasms are quite specific. The child presents like somebody in pain. They will probably bring their head down, their hands up, their legs up, and this can happen several times within a few minutes, and then it stops, and then the child starts all over again. It's quite a scary thing to watch. It causes concern because this mom feels like her baby is having tummy aches. And if they're observant, they will also notice the changes in their baby. Once that starts, and that is why it's a very important form of epilepsy for us as healthcare workers, it is important because children lose milestones, children move backwards, children lose abilities. And unfortunately, it's associated with permanent changes in the brain. Even if the baby is treated, it's possible to stop those kind of seizures using very specific medications, which are not even used for other forms of epilepsy. And unfortunately, those are babies who, even if the seizures stop, they tend to be behind their peers, because whatever is causing an infantile spasm is usually a serious problem. So that is one answer. Then for spasms, spasms are things that we see in children with cerebral palsy. For example, if you bang a door, under normal circumstances, you will wonder what it is that has happened. But because the regulation of the muscle activity in a child who is already known to have cerebral palsy is not well regulated, so you may find that they actually are not just startled, wondering what's happening in the environment, they may also have certain sudden movements. But how we differentiate spasms from seizures is that, one, a spasm always is caused by something. I've talked about a sudden noise, moving the baby, undressing the baby, changing the baby's position, something. It is something you have done that causes a spasm. And one of the ways a parent can differentiate that from a seizure is that spasms, once you hold the baby or you hold that hand that is, or that arm that is having the unusual movement, it usually stops, and usually stops completely. But seizures, you cannot stop them, as I mentioned earlier. It does not stop, it just continues until such a time when either the seizure itself dissipates or the baby is given medication. So usually that's how to differentiate a spasm from a seizure. A spasm is caused by something. You can actually make the child have a spasm even in clinic, because you just have to do something and then the parent. For spasms, we generally don't have treatment. Occupational therapy helps reduce the spasms, especially so as the muscle becomes less tight. For babies who are also on muscle relaxant medications, they also tend to have fewer spasms. Does that help?
Yes, that really helps. At least there is guidance.
Okay.
There is another question in one of the caregivers group where the mother has asked, when the jacks start in the leg and then progressively go to the upper limb, she's concerned and wondering, does the child have pain during a convulsion? Is it something that we're aware of? Are they in pain? Or what causes the crying after the blacking out? And you know, because I know, like for my own child, he will black out and sleep for like an hour after that. What's the exhaustion? Or is it exhaustion? Is it, and then all the crying? I'm sure you get my point on that one. So this one, is it painful? And two, because of course we see, for us to see the child crying, so of course there is a discomfort. So is the jacking painful, or what exactly is going on? And what do you call this? The reactions after, where they sleep or they become immobile for a very long time. What actually just goes on to make it that way?
Okay, so the basic problem when children have epilepsy is that the neurons are not well coordinated, so to speak. Right now, we are holding this conversation because the brain selectively allows the muscles that produce sound to work, whereas the muscles that allow you to walk are sort of not muted, but they're not activated at this time. So when somebody has a seizure, that sort of coordinated way in which things exist is completely disrupted. It's like the way we are holding a good conversation here, we take turns, we try and understand each other. During an epilepsy, it's like all the neurons are firing at the same time in a chaotic and disorganized fashion. And therefore, their presentation of what you see is many unusual things, like the staring, the shaking when you actually shouldn't be shaking, the inability to respond, or even children who say very odd things during seizures. And then they're confused. And sometimes, because of the abnormal brain activity, they will cry. Crying could be as a result of fear that they feel because some part of them is still aware that something is happening. It's also scary. It's mostly a scary event, but the crying is usually not because of pain. They're not in pain. It's just that whatever is going on in their brains at that time is basically abnormal. They're not supposed to be crying. For example, the children who cry in their sleep, they scream, right? It's as a result of abnormal brain activity. It's not that the child is in pain somewhere. And once this abnormal brain firing dies down, then the brain is exhausted, then they go, that is why they go into a deep sleep. At that point in time, they're not capable of doing anything else apart from maintaining the vital activities, such as breathing, the heart is beating. They can't really do anything else. So it's because of exhaustion of the neurons. So they go into sort of like a resting state, and therefore you're not able to wake up your child, and your child at that time is not able to do anything. So they're not in pain. It's the crying is as a result of abnormal brain function happening during the seizure.
Wow, this is a masterclass.
Well, I'm trying to break it down, but that's what it is. And I think that is
exactly why we do this. And that's why we correlate NEURODIGEST, because we want to digest everything of what is going on and break it down. And I appreciate all this knowledge that you're sharing, because now at least, because sometimes we end up breaking down, imagining that our children are in so much pain, there is nothing I can do for my baby. It renders you to feel like you're useless at that point and as a parent. So we have Nina who says she gets the seizures herself, and she's wondering about epilepsy and asthma. I've requested for her, or she has both conditions. So she's wondering if asthma in itself leads to epilepsy. And she also says that when the seizures come, it creates a lot of fear. So I think it's an aura for her. I think it's an aura, right? You can expound on aura and all these other things. Back to you.
Thank you, Nina. That's a very helpful question. Those are two independent conditions. There are very many people who have asthma and they do not have epilepsy. And there are many people with epilepsy and they do not have asthma. So you will find yourself needing to see like two different doctors to help you. So of course, there are people who are quite conversant, like physicians and pediatricians, who are quite conversant with both conditions. And so they may be able to guide you. One does not lead to the other. There are two different systems. One is the what we call the respiratory system, or basically the chest. And the other one is the nervous system. So those are two different systems. Those are two different conditions. And if both of them are needing active management, it, it just calls on you to actually actively manage both. Luckily for some people, asthma can be seasonal. Like during this time when it's a bit colder, you can see the way I'm dressed, it's a bit cold. They may have more asthma episodes, whereas epilepsy is very unpredictable for majority of the people. The seizures can happen at any time. So Nina, thank you. That was a nice question.
All right, thank you, Daktari. So we have a question from a parent who's saying that the daughter has
Sylvia.
CP. Yes?
Sylvia,
Yes?
I have a question.
Yes. Yes,
I wanted to ask Daktari.
Mm-hmm.
I want to ask Daktari,
Mm-hmm.
are there particular types of food that trigger seizures?
Actually, not really. No, we do not have uniform types of foods that cause seizures. However, alcohol in our adolescents and adults makes it much easier for them to have a seizure other than, under normal circumstances. Alcohol is one of those things that makes it more likely for you to have a seizure than not. Having said that, we know there are certain foods which if you take in large quantities, you're less likely to have seizures. Just removing starches from the diets of many children with poorly controlled epilepsy, that means the epilepsy that is not responding well to medication, that in itself has helped reduce the number of seizures for most children. So it means that they'll be taking more of animal protein, maybe foods with oils like coconut and other nuts, maybe more of eggs. So that, to the contrary, there are foods we know, including things like avocado, fish especially, that if you take them in large quantities and reduce the starches, you're less likely to have seizures. For your individual child, I've heard of a mom who says, anytime my child takes cold food, he gets a seizure. Our postulation, or what we think, is that maybe when this child is exposed to cold, they may have a reaction in their body, or they may be a bit more sensitive to cold weather, cold foods. And so the way the body reacts to that change, they end up with a seizure. So we don't think it's the food itself, but what she tells us makes us think it's more about the temperature of the food and how the body reacts to it. So we're not aware of foods that cause seizures.
Okay, thank you. But I've learned something that some can be triggers, yes?
Yes, yes, we've heard of that. So
it's not a cause, but a trigger. So there is a difference. It's not causing it, but it can trigger it to start the episode. Yes.
Somebody called Papa Bench wants to ask a question on audio, Sylvia.
So my name is Nina. Sorry, I might have got you confused. My name is Nina, and I started the Papa Bench Initiative. It's an epilepsy.
Nice to meet you, Nina.
Nice to meet you too. So Dr. Pauline, my question was about epilepsy and seizures, was that when I was much younger, much of the time I was found lacking oxygen, whether it was in nursery school, I'll turn blue. And then, shortly after is when my seizures actually started. So when that happened and I was checked and found out that I had epilepsy, then we kind of correlated this to, you know, the asthma, because the asthma was bad at that point. And we thought that maybe it could have been one of the things that actually caused the epilepsy.
Okay.
Yeah, thank you for the explanation.
All right. Thank you. All right. Now, I just want to take the discussion to now management of the seizures. Now, we always get medication to try and manage seizures and the whole epilepsy so that at least the children can be stable. But you find there are moments in time when you're given either multiple medication, and then we find at times people say that kids react to some of the medication, that new behaviors come through. And we also have a question also where there's a parent who's saying that the daughter has CP and she keeps making loud sounds. She's wondering, is there anything that she can do to stop the noise? Because the child is already on medication. And she's on different sets of medication. So she's wondering, like, okay, what exactly is that on?
Okay, yes, I can see the question from Catherine to everyone. It's a good question. It's something we have seen. Basically, what this means is that the seizures haven't responded fully to the medications that this baby is on. Well, as care providers, we generally try not to ever stop until such a time when we find a combination of medications that is suitable for the individual child. The management of epilepsy, is what I tell my residents, is not a one-size-fits-all. We have children who are very lucky in the sense that actually 80% of the kids we see will respond appropriately to the first medication that we choose. And all the seizures go, we may need to make adjustments along the way, but they don't need any other medications. Then we have another group of patients where even 3 or 4 medications do not completely stop the seizures. That's not very common, but what we would tell Catherine is that somebody needs to review the medications her child is on and try to see if there is something else that has not been tried apart from what she has stated on the group. Why? Because now, over time, we have discovered, or we have access to other medications. I can name maybe 4 or 5 others which are not on that list that can be tried for her child. And if they're found suitable and to give her better quality of sleep, stop the screaming, that would be good. So yes, I've had a child like that who, it was uncomfortable for the family because the neighbors would hear these sounds at night and come and ask, what is wrong with the child? Why is she screaming? So it took us a couple of months to change over one of the medications. Actually, what we dropped was Epilim, and we actually gave the baby the Babiton, and in that she's perfectly fine now. So there are many others which would have to be tried for this specific child. What works in one child is not necessarily going to work in another. So some children react very badly to Rivotril. There are others who cannot do without the Rivotril. So treatment has to be individualized. And I think Catherine needs to find somebody who probably can evaluate the medications and see what else can be added or changed or removed so that the quality of life for her child and the family is better.
Okay, thank you, Dr. for stepping in for Catherine. The other question that most of us are always hopeful that at some point the convulsions will stop. And the sad reality on the ground with the current situation we're having lack of access of medication, but you find we are consulting amongst ourselves as caregivers. I'm using this is equal to this, which I know is not a good practice, that we shouldn't be doing that in terms of what your child is using would not suitably work for my child. But when it comes to the combinations and how long one takes, I know it varies from child to child, but in your experience in the many years, how long and what percentage could we say of children actually eventually stop relying on medication to control the convulsions?
Okay. It may vary also from location to location and the reason for the seizures, but where I work, about 80% of the children are easily controlled with one medication, but you'll also find that it's children who tend to have genetic causes for their seizures. You know, the MRI brain will be normal. But there are many children who within 2 years, their seizures have stopped, and medications can be de-escalated for about 80% of them. But we have another group of 20 to 30% who, it doesn't matter what you do, you most likely end up with reducing the number of seizures, but you find that maybe occasionally in the morning the child will still get one, and therefore it becomes a discussion between the practitioner and the family about what is in the best interest of the child. To be honest, you can actually stop all seizures in any child. You can give so much medication or enough medication such that that child is not capable of having seizures. Now, the downside to that in some situations is that yes, you've stopped the seizures, but you're now not having a functional child. The child is either too drowsy or the behavior is not appropriate, and especially so the drowsiness bit. We have really potent medications that can stop all seizures. So once in a while, we will sit and discuss with the family that it is better that we give this amount of medication. We know it will not stop all the seizures, but at least your child will be happy, able to interact with you, able to play, interact with the other children in the house, not be drowsy and drooling all the time, but they will still have that occasional seizure in the morning. Rather than I give enough medication, you're not seeing any seizures, but on the other hand, the child is not, is not really with you, is not functioning appropriately. So it's a compromise, but before we get to that compromise, we will have tried appropriately in proper doses, different medications. So for parents to be, trying different medications without guidance for their individual child, it's probably not a very good idea. I know that we're not very many practitioners in the country, but that is set to evolve because we have now started training our own pediatric neurologists. So it is possible that in a few years to come, that wherever it is you live in the country, there'll be somebody easily accessible to you. But in the meantime, please find somebody who understands these medications and who can help you, even though it is during the COVID time. Why I say that is because during this time, we've noticed that a few children have gotten COVID, but the vast majority, we have not even admitted them. They have been managed at home because their illness is mild, and the people who are getting severe disease are the adults. So please don't fear to go to hospital, especially so for a child who is suffering. I do not know of any hospitals now who have closed their pediatric clinics. So the advice to families is to take reasonable precaution. Do not put masks on children who cannot speak for themselves and tell you that they're uncomfortable. Do not put masks on children who are less than 2 years of age. You should wear your mask, carry your sanitizer, stay away from people who are coughing, try not to be in confined places, make your visits to hospitals short, but please take your children for care.
Wow, thank you. At least we've touched on the COVID, because I know a lot of us would like to, that's a question we are struggling with. Do I go to hospital? Am I increasing the risk of now COVID on top of that? I know we lost a child the other day because of convulsions in the middle of the night and the effects of the curfew, not knowing what to do. I know we are not supposed to panic, but naturally in this case, you will panic without knowing what to do. Also considering the financial implications of COVID-19. So it's putting us caregivers in a very tight situation. I want to go for that review, but can I afford it? Because we have people who are not even able to afford the medication. Looking at the moment, the way Rivotril is not available, and guys are getting different prescriptions, and it ends up being so expensive because it was affordable. And now you're looking at the new prescription is something way beyond your budget. So those are some of the things that are limiting factors that you find that now caregivers are being torn of how to take this conversation forward. So we have someone else asking, she says, thank you, Dr. Samia. The discussion is very informative. Which is the least acceptable number of convulsions that a child can get daily despite being put on medication, like 4 drugs? Wow, 4 drugs and the convulsions are still there.
Okay, I do not know the name of the person because it says TechnoCX Air, but still we will answer the question. Our target when we start seeing children is actually to have 0 seizures. 4 medications are rare in our clinic. Some years back, before we had more effective medications, yes, a few people used to be on 4, but we really try to use the 2 most effective medications for an individual child. So our goal is usually to have 0. So if you're not achieving that on the 4 medications, then maybe somebody needs to look at the doses. Are all the doses right? Are all the medications actually making a difference for your child? Is there anything else we can offer you, like a dietary therapy, or maybe a short-term steroid, or a different kind of medication? I think that if a child is having very many seizures while on 4 medications, I think we need to rethink the whole situation. Is there any surgery that can help? Sometimes you're told no, sometimes you're told yes. So I think that something else is, something needs to be changed there, especially if the seizures are very many and you feel that the child's development is not okay. It also depends upon the underlying problem. 4 medications, I would say, are on the higher side. I think there needs to be an evaluation somewhere.
Okay, so I hope the parents have picked that from that. Now, the other thing I have noted, is there any relation with, especially for the autistic children, and triggers of convulsions? Because you will find, or I've noted in the recent past, that once they get to teenage, a child who's not had a convulsive order before starts getting it. Is there any relation as to why this is happening?
Yes, Sylvia, medicine is very interesting. I find it very interesting in the sense that when you're told that a certain disease presents and progresses in a certain way, usually that's what happens. So for our children with autism spectrum disorder, you'll find that when they're younger than 5 years of age, only about 1/3 of them have epilepsy. But once they hit teenage, that flips to about 75%. 50 to 75% actually, let me not say 75%. It's actually a range of 50 to 75%. But that is what happens. You find that when they're younger, only a small proportion of them have epilepsy. And as they grow older, now children who didn't used to have epilepsy now have the dual diagnosis. It is thought to be because of ongoing maturational processes in the brain. And that is why that observation is made. As children with epilepsy continue to grow, there are changes that happen in their brain, just like everybody else. I mean, if you sit and think about it as a parent, how you used to think when you were 16 years of age and how you think when you were 26 is very different. What's changed? It's just maturational processes in your brain. So as a result of that, and sometimes changes within the neurons themselves, then they're more likely to have epilepsy. It's a trend that has been observed the world over, not just for Kenyan children.
Oh wow, that's so we for us for the ones who are not there, it's something to watch out for and be mentally prepared, because yeah, there is a lot of panic in that space, because all of a sudden.
No panic, Sylvia. No panic. We deal with issues as they arise. We enjoy our children on good days when they don't have seizures and they're happy. We have fun that day. When there is a crisis, we deal with it as it happens. And some of these things are not really in your hands. It's not because there's something you failed to do as a parent. And when the baby or the child is 5 years of age, we cannot do or give certain medications to prevent seizures when they're older. So it is part and nature of the illness. Maybe that's the easiest way to look at it. So don't worry about it. If it happens, we sort about it. We sort it out. If it doesn't happen, then it's okay. We deal with things as they arise.
We deal and move on and embrace the new that is there.
It is well.
All right. Okay. Thank you very much. It has been actually a very informative session. I wish we could have you for longer, and because I know there are very many questions. Maybe we'll host you another time, and maybe you'll be able to also take us through the details of autism and development, and not really development, but like to just generally understand the neurodiverse in itself. You know, the way you took us through the pregnancy and how it affects the brain and all that. So at least we've learned to embrace and understand what epilepsy is all about. So I would like to pass my sincere gratitude for taking your time. I know you're a very, very busy person, and at least you've given us some hope and some good news that at least you're training more pediatric neurologists, so at least we won't have to sit outside hospitals until 1 a.m. I know we are forced to do that sometimes, you know, and wait long hours just for the sake of having our children in a good space. And for everyone who joined us, we'd like to also say thank you. Those who've joined us here on Zoom, and those who are watching us from home through Science TV, thank you very much. We've had our guest, that was Dr. Pauline SAMIA from the Aga Khan University Hospital, talking to us about epilepsy and seizure. And I've been your host, Sylvia Moraa Mochabo, from the founder of Andy Speaks. And as always, we say, take care of your child, take care of yourself, make sure you are okay so that your child will be okay. They will be able to sense it when you're overwhelmed. They will be able to know something is wrong with mommy, and it will give out also now more meltdowns and stuff like that. So don't forget, you, as you're taking care of yourself, take a me time, even if it's once in the week, so that you are fit as a fiddle to be able to take care of your child. So next week, we shall be hosting Winnie. We will be discussing menstruation, neurodiversity, how to handle it. How do you handle your child during the period? How do you teach this to them? So we will be resuming our regular time for the NeuroDigest show at 2 p.m. next Saturday. And after that, we shall be hosting Dr. Susan, who will be talking to us about development and neurodiversity. Why do our children slag behind? What causes it? What interventions? How do we rehabilitate them so that they're able to perform at their peak? So we have a fully packed August for you, and we hope you'll be joining us every Saturday, 2 p.m. for the same. Thank you, Dr. Samia, for making the time and for joining us today once again. And we shall see you all next week. And if you're not following us also on social media, please make sure you do so on Facebook. We are on Twitter as Andy Speaks 4. And on Instagram as Andy Speaks, and on Facebook we have our private group where we can encourage and teach each other and share our experiences as caregivers. That is Andy Speaks for Special Needs Person, in brackets SNP, on Facebook. And for those who have joined us late, don't fret. We will be uploading this episode on our YouTube channel, that is Andy Speaks for Special Needs Persons. Follow us so that you get that notification. So thank you and have a good night, and remember to enjoy tomorrow. It's a Sunday and we hope it's going to be a sunny day. Thank you, Dr. Pauline, for being with us today.
Thank you very much for inviting me, and have a good evening as well. Thank you. Bye-bye.
All right. Thank you. Bye.